Hi, my name is Matt Davis, and for my presentation today, I'm going to be talking about haloperidol, but just for simplicity's sake, I'm going to refer to it as Haldol in this presentation. So I'm just going to move through the different prompts that are outlined in the assignment, starting with drug profile comparison, and then I'm also going to kind of implement symptom management in that discussion, just to kind of keep things, concise with time. But Haldol, as we know, is a first generation antipsychotic that's primarily used in the treatment for schizophrenia, as well as addresses psychosis, and can be utilized for Tourette syndrome. Like other FGAs, it works by blocking D2 receptors in the brain, and it works primarily along the mesolimbic pathway, so it helps to reduce hallucinations and delusions, but then also help to improve cognitive function. But there are also a number of things that separate Haldol from other first generation antipsychotics, namely its potency and its pharmacokinetics. So with potency, Haldol is classified as a higher potency drug, meaning that it just takes a smaller dosage to be able to achieve therapeutic effect, which obviously has some advantages in that regard. And then its pharmacokinetics. So with pharmacokinetics, it has a longer half-life compared to a lot of other drugs. It's usually about 15 to 36 hours. And this is great because then this can be used as just sort of like a once daily dosing. So patients that are prescribed this can just usually take it once, usually at night because of the sedative factors, but they can just take it once a day. Um, when it's given IV, can also have a really rapid onset, and this is great because especially like in ICU settings or palliative care, or those that are confused or agitated, Haldol can be used to help calm a patient that is aggressive or is really confused in that regard, because then it'll calm them, but it won't have the same level of sedation than, say, like a benzodiazepine. So, really, really great there. Other advantages to this is that it can be given in long acting injectables. So, we know that a lot of people in psychiatry that are prescribed medications oftentimes have really poor medication adherence to their regimen. So, having a medication that can be given as a long acting injectable is great, because then that's usually only given like once every 4 weeks. So it's a huge advantage. And then lastly, another advantage is that it's fairly cheap. Haldol is, it's widely available, so it's great for facilities that are also limited on resources. Um, Moving on, so I've kind of talked about those first two sections. I'm going to talk next about age-related considerations. And there's a number of them, but to kind of put it in a nutshell, Haldol is not typically used for people that are under the age of 13. The FDA doesn't approve of it, but it can be used in adolescents, especially when like Tourette syndrome is being addressed. And I think that's where we see Haldol being used more. Um, it has a lot of effects on the developing brain, and younger people can be particularly sensitive to it, which is why it's not indicated. But elderly are actually at greater risk, and that's for a number of reasons. They have lower metabolism, so they're at greater risk for accumulating the haldol within their body, which can, of course, risks toxicity. They have lower kidney functioning, so the clearance rate is decreased, also posing higher risk for accumulation and toxicity. And then because of its sedating factors, it can pose them at risk for falls, at greater risk for being able to fall and then hitting their head and causing farther complications. Also, it has higher instances of mortality rates in this population. So we have to be very careful when prescribing Haldol within this population. Um, Medical rule outs and other cautions that we want to be aware of when we're prescribing Haldol is that it's contraindicated in several conditions, especially when we're talking about Parkinson's, because that can actually exacerbate the symptoms and make them even worse. People that have central nervous depression would not be good candidates for this medication. And then also those that have, respiratory failure, because, this can, again, the sedating effects can suppress the respiratory system, and that can lead to further issues. Something that we may or may not be aware of is that Haldol can actually prolong the QT interval, so that can, lead to arrhythmias. And the indication for this is that if a patient comes on in, and I'll talk more about the things that we want to be able to address with like labs and so forth. But the QT interval, we want to get an EKG, and if it's longer than 500 milliseconds, or if we prescribe somebody this medication and there's a change in 50 or 60 milliseconds or greater, then this is clinically significant, and we should either not prescribe Haldol or we should change to a different medication. Also, it can lower the seizure threshold, so we don't want to be giving it to anybody that might be at risk for seizures. And then lastly, when I talk a little bit about side effects, anybody that has a history of neuroleptic malignant syndrome, or NMS, we want to be very cautious in prescribing that, because NMS is the single greatest factor or determining factor for having another episode. So, we have to be very cautious with that. So I kind of talked about a number of things there, but with regard to monitoring, there's a couple of things that the clinician should be doing. So I mentioned that they should be getting a baseline EKG just to see what their QT interval would be and if there's any arrhythmias. We also want to look at liver function panels just to see how their liver is, just because metabol is metabolized by the liver and then is also eliminated by the kidney. So we want to be able to see if there's like a history of acute or chronic kidney failure, because the way that's going to be metabolized and cleared could lead to risk of toxicity. So we want to get those labs. Haldol can also lead to hyperprolactemia. So that's not necessarily indicated at baseline, but that's something that you want to get a lab of if the patient's showing signs and symptoms of those, primarily if they're showing like galactorrhea or breast development, especially in males. And then also you want to get a neuro assessment. That's at baseline, and if they're showing any confusion or deterioration, then we want to be able to continue to assess that. EPS symptoms, we can use the AIMS assessment or the abnormal involuntary movement scale if they're showing early signs of EPS or extrapyramidal symptoms, because that's going to be a huge side effect. And on that note, I'm going to talk about side effects. I know I'm over here in regards to time, but EPS, that's the one that we want to be most cautious of, with the exception of NMS that I talked about. But again, you can actually offset a lot of these symptoms with EPS, either by, like I said, adjusting the dose and titrating down, or just switching out the medication. You can also prescribe adjunct medications such as an alpha-2 adrenergic agonist like clonidine, or anticholinergics such as like benzotropine. Even though the FDA doesn't actually technically approve of that, it's usually used off-label in those settings. Or you could even use something like a beta blocker like propanolol. When it comes to NMS and somebody who is presenting with that, and again, that's characterized as a rare but potentially life-threatening condition with muscle rigidity, fever, altered mental status, autonomic instability, elevated creatinine levels, and this can be done with supportive care, hydration, and then you also want to be able to give something like dantrolene to help as like sort of like an antidote to that, or to help to reverse those symptoms, because again, that can be very life-threatening. Other side effects is that they could potentially, even though Haldol has a lower propensity for weight gain, we want to be able to get a waist circumference and be able to take a look at that, just because we don't want patients having that issue, because that can lead to further lifestyle implications. And then lastly, with regard to education, we want to promote adherence to this medication, because stopping these medications can lead to decompensation and then sudden relapse for withdrawal symptoms and psychotic features to resurface. And then we also want to be able to promote lifestyle modifications, such as staying hydrated, avoiding alcohol. Especially for those that are elderly, we want to encourage them to rise slowly out of bed to prevent that dizziness because of those sedating features. And so I think that if by empowering these patients with these sort of pearls and education tidbits, we can help to promote safety and then also help to improve their lives ultimately. So I know I'm over, but that's my presentation. Thank you.